Hello and welcome to the Metabolic Classroom. My name is Professor Ben Bikman. I am a biomedical scientist and professor of cell biology. In today's Metabolic Classroom, the topic is the metabolic consequences of medications used for mental health. So this includes antidepressants, but also I want to make sure that the conversation includes some discussion of anti-anxiety medications. They're different, but there is, of course, a tremendous amount of overlap. Speaking of overlap, there is also a great deal of influence or crosstalk between mental health disorders and metabolic health. Mental health disorders like depression and anxiety are closely linked with metabolic conditions like insulin resistance and the eventual manifestation or the end result or the end consequence of insulin resistance, namely type 2 diabetes. Now, over the years, this relationship has been known, but not clear in the directionality. And to complicate matters, it seems like it's a bit bidirectional, that depression can lead to metabolic disturbances. However, existing metabolic disorders can actually also worsen mental health symptoms. And that's certainly the paradigm and the directionality that I'm approaching with this topic. Now, to further complicate this and even give some justification for the time that we're going to spend talking about this, it's very well known that myriad anti-anxiety and antidepressant medications can themselves lead to significant metabolic side effects like weight gain and insulin resistance. Now, as I approach this topic, I do so with a great deal of respect, and I want to admit it very openly. I don't like it when scientists claim an expertise across all areas, or when someone with some glamorous terminal degree after their name, an MD or a PhD, for example, that they then believe that makes them an expert on everything. There's this phenomenon, and it is a very fun word, ultra-crepidarianism, which is this term that refers to people giving opinions or advice on matters that are outside of their actual knowledge or their area of competence. This would be like famous physicists who have suddenly become experts on microbiology and understand viral transmission and vaccine function, for example. So let's just set that stage very, very well and thoroughly. I'm not a clinician. I'm not a psychiatrist. I'm not even a neuroscientist. I'm a metabolic scientist, and that's how I am approaching this topic. Now, I'm a professor of physiology, so I can speak about some of this topic comfortably and qualify as your teacher for the next 20 or 30 minutes. So thanks for letting me, of course, as usual, just be a teacher here. Okay, now to get started, before we actually describe commonly used anti-anxiety and antidepressant medications, I wanted to start with establishing a foundation, namely by focusing on the key neurotransmitters that are altered, either altered in a way to create the problem and or altered in a way to help solve the problem. Those aren't necessarily sort of the same thing. But nevertheless, there are a few key neurotransmitters. There are more than I'm going to cover. I'm going to mention three, and I just want you to appreciate that there are more. You would have no trouble finding more, but for the sake of time, I'm just focusing on the big three. All right, so let's just start with a review of what the neurotransmitters are, their general role in mental health, and then I'm going to highlight their role in metabolic health and metabolic function. Then we'll get into some of the specific medications and their influences on metabolic health. But having started with a review of the neurotransmitters, will make much more sense. So the first neurotransmitter I wanted to discuss is serotonin. You may also see it sometimes indicated as 5-HT, and that refers to its more technical chemical name, 5-hydroxytryptamine, but let's just call it serotonin for goodness sakes. All right, now serotonin is a key neurotransmitter involved in regulating mood, anxiety, and just overall feeling well. Low levels of serotonin have been linked to depression, anxiety disorders, and even sleep disturbances, which if you've followed me for some time, that's something I personally struggle with. All right, so that's the general role of serotonin as a neurotransmitter in the central nervous system. Let's, particularly with regards to depression and anxiety. However, even if we stick with the central nervous system, in other words, the signaling of serotonin in the brain, it has a metabolic relevance, in particular with regards to appetite. And later on, I'm going to revisit this idea of cravings and food addictions. And I'll just touch on that lightly as we go across the three main neurotransmitters. But serotonin is a contributor to appetite suppression. So it is like acting kind of like leptin is in this canonical sense, where it is signaling a satiety. It's telling the brain that, hey, we're full, let's not eat anymore. So it's no surprise that high serotonin levels are associated with reduced hunger, while lower levels may increase food cravings. Not cravings for everything, though. This appears to be particular to carbohydrates and sugary foods. And again, that's a topic we're going to revisit again at the end. Now, let's go firmly into the metabolic and leave the brain behind and get into the realm of the systemic or peripheral signaling of serotonin. So insulin sensitivity. Serotonin impacts insulin regulation in peripheral tissues, especially some key tissues like liver, pancreas, and adipose tissue or fat tissue. We're going to talk more about fat in just a second. But if serotonin isn't signaling well, insulin isn't signaling well either. And so insulin resistance and type 2 diabetes risk goes up. Now, let's talk about the fat cell in particular, serotonin. So first of all, there's this promotion of fat accumulation. Serotonin can increase lipid accumulation. And this has been shown to happen in both rodent fat cells and human fat cells. And this is by activating the central regulator of fat storage and adipogenesis or fat synthesis, fat cell synthesis, called PPAR gamma. So that's PPAR dash, then the little Greek letter gamma, PPAR gamma. You can look this up for more details, but PPAR gamma activators are classes of medication that, among their handful of metabolic effects, are most well known for making a patient gain a lot of weight. So serotonin activates that same thing. So it can lead to greater fat storage and upregulation of the genes that are associated with that process. Okay, at the same time that serotonin is stimulating an increased fat storage, it's also through the receptor that we could just call serotonin receptors, but technically they're the 5-HT2A. So to say all that another way, the serotonin 2A receptors, it can inhibit lipolysis. So that lipolysis is the term for the breakdown of fat. And that, of course, is going to drive the fat cell to continue to store more fat. Also, reflective of this general kind of suppressive effect on mobilizing energy and rather storing it, serotonin has been shown to prevent the differentiation or the maturation of brown fat cells. It interferes with this process of the brown fat cells becoming really mature and kind of grown and functioning. And then lastly, serotonin inhibits thermogenesis. And that is very much a brown fat phenomenon. That's something we've talked about previously, this idea of mitochondrial uncoupling, where you have the mitochondria basically like an engine where you are, if you can imagine, you're in neutral or you're in park and you're revving the gas pedal. So the RPMs are going up and yet you're not moving anywhere. That's this idea of uncoupling, where the cell is working, but it's burning through nutrients and it's just creating heat. It's not actually getting any work done. Like you pressing on the pedal, the gas pedal, and you're not actually moving. Okay, so that's a review of serotonin. Let's move on to the next of the big ones, namely dopamine. Now, its role in mental health is that it is one of the more famous reward neurotransmitters. So it regulates this degree of motivation and pleasure and behaviors associated with, finding something that makes you feel good. Dopamine imbalances are associated with mental health disorders, including some big ones like depression, bipolar disorder, as well as schizophrenia. All right, now that's the central effect with regards to canonical mental health outcomes. And let's stay in the brain for just a moment, like we did with serotonin, dopamine, but move on to metabolic. Dopamine plays a role in regulating energy expenditure and appetite. So when dopamine levels are low, people tend to feel more inclined to overeat, particularly foods that offer a reward. So this is generally going to be sugary foods or sugary and fatty, or starchy and fatty. That is a particularly rewarding combination. Naturally, that can promote weight gain, but we'll get into that in a little more detail. Remember, this is just meant to be an overview of the neurotransmitters. With regards to insulin sensitivity, now getting out of the brain into the systemic or peripheral tissues, dopamine does affect glucose metabolism, and that when dopamine levels are blocked, like some medications do, we'll talk about this, it can reduce insulin sensitivity and contribute to the development of insulin resistance, even if a person isn't necessarily gaining weight. So it's suggesting that dopamine is favorable with regards to insulin resistance. Also, with regards to brown fat, dopamine directly stimulates thermogenesis, or the activation of brown fat, by increasing this uncoupling. And at the white fat cells, where we store most of our fat, in contrast to serotonin, dopamine activates lipolysis, so it's stimulating the breakdown of fat. All right, now let's get to the third and final of the big three of the neurotransmitters, namely norepinephrine, also known as noradrenaline. You've heard of adrenaline before, also known as epinephrine. This is norepinephrine. It's sort of a very closely related sibling to epinephrine / adrenaline, but it's more specific in the with neurotransmission, or the signal coming from a nerve to a tissue, to a different cell. All right, the role in mental health. Norepinephrine is a neurotransmitter and a hormone that is involved in the body's sympathetic nervous system, or what's commonly called the fight or flight response. So typically it'll increase alertness and focus and just awareness. But low levels of norepinephrine are associated with depression and fatigue. Of course, high levels would be associated more with anxiety and hyperactivity. Okay, let's get right. It's once again sticking in the brain, but into the metabolic realm. Norepinephrine suppresses appetite when it's acutely elevated. But if it's chronically elevated, like with long-term medication use, it can actually start to shift into the other realm, reducing appetite and so increasing hunger. With regards to energy mobilization and its effect at fat tissue, it's very, very well documented. It stimulates fat breakdown. It activates thermogenesis in brown fat. So it's really accelerating fat metabolism. Okay, now with all that being said as groundwork, now you know what the main neurotransmitters are. Let's talk about the medications that are commonly used in order to combat anxiety and depression at a very, very high level. I'm not a neuroscientist. I'm not a psychiatrist. I'm just your friendly neighborhood metabolic scientist. So we're going to just briefly mention the primary effect of the drug in the context of mental health, and then move on to the metabolic effect. Now, let me say, a lot of what I am going to say based on the sum of evidence is, in some instances, like with the first ones we're going to talk about, SSRIs, it's really debated on the degree to which they actually are effective for mental health. So please don't take what I'm about to say as my own endorsement for the use of these drugs. I think it's very appropriate for people to really dig through the data, and of course, working with your medical provider, make sure that you are actually embracing an approach that will work. But having said all that, let's start with the first one, as debated as it is: selective serotonin reuptake inhibitors, SSRIs. So the mechanism whereby these work is, and this is drugs like fluoxetine, sertraline, and more. They function by increasing serotonin in the brain. Now, this does have a spillover effect of increasing serotonin in the systemic circulation, or in the blood outside of the brain. But by inhibiting the reuptake, the serotonin stays at that, what's called a neural cleft, and now can spill around throughout the brain and throughout the body. But because of the higher serotonin, it is thought to help stabilize mood and reduce symptoms of depression and anxiety, with admittedly some conflicting results. Now, what about the metabolic consequences? The long-term use of SSRIs is associated with weight gain and insulin resistance, Despite a little initial weight loss, it tends to be weight gain happening, and this is generally thought to itself be a process of an increased appetite. Now, not an increased appetite for everything, as you'll see in some of the show note links. This always appears to be particular to something that is sweet and gooey or salty and crunchy. In other words, carb heavy. Okay, the next class of medications, these are the TCAs or the tricyclic antidepressants. These are drugs like amitriptyline or doxepin, and this blocks the reuptake of serotonin and norepinephrine. So it's increasing both of them. But it also can affect other signaling molecules like histamine and acetylcholine and their receptors. So I've introduced now a couple other neurotransmitters, even though I said I wouldn't, but they are part of this TCA family. And again, the side effect here being an improved mood. That's the mental health mechanism. But there are some metabolic consequences. TCAs are strongly associated with weight gain, insulin resistance, and dyslipidemia, so higher triglycerides. The increase in appetite, once again, particularly for carbohydrates, coupled with a reduced metabolic rate, as seen commonly with these medications, really does contribute to some pretty significant weight gain. All right, let's go to the next one. Monoamine oxidase inhibitors, MAOIs. This is probably the most common of these drugs is phenelzine, and these prevent the breakdown of serotonin, dopamine, and norepinephrine, so all of them, increasing their levels in the brain and thereby generally providing some relief from depression. These aren't as prescribed as often nowadays, but these MAOIs are associated with weight gain and insulin resistance due to some of the changes in the appetite regulation and systemic fat cell metabolism. Okay, next class, atypical antipsychotics. These are used for depression and anxiety. These are one of the more common ones, like olanzapine, for example, and this works by modulating dopamine and serotonin receptors, and it's thought to then help stabilize mood and anxiety and manage even some more serious psychotic symptoms or symptoms of deeper psychoses. That's the mental health focus, which again, I'm not a neuroscientist. I'm not a psychiatrist. I'm the metabolic guy. So let's move on to the metabolic consequences. These drugs are strongly linked to severe weight gain, insulin resistance, and metabolic syndrome that follows. They also can disrupt appetite regulation by affecting hunger and satiety signals in the brain, which will often lead to much greater consumption of food in general, but once again, a craving for high carbohydrate foods, either alone or with fats. Additionally, these drugs have been shown to directly impair glucose metabolism, thereby increasing the risk of type 2 diabetes. There's a couple good studies you can read on that I have linked in the notes. Okay, let's just do a couple more. One more is another drug, an antidepressant called Mirtazapine. It works by antagonizing or blocking specific, like very particular receptors linked to serotonin and norepinephrine. And this means that it keeps those neurotransmitters higher for other receptors, the ones that we want serotonin and norepinephrine to bind to. In the process, improving depression symptoms. Interestingly, it also has some sedative properties. So this drug can also sometimes be used for people with anxiety and sleep disturbances. Now let's go from metabolic health, from mental health to metabolic health. Mirtazapine is associated with significant weight gain, particularly with increased fat mass and leptin levels, which of course, if leptin is chronically elevated, the body becomes leptin resistant. And there's not a direct effect of this drug with glucose metabolism. However, as the person's gaining weight and fat cells are growing, naturally that increases insulin resistance. Now, those were the main ones that had the most evidence to support their concern with regards to metabolic health. There are so many different types of drugs within the family of anti-anxiety and antidepressant medications that we would simply not have time to discuss them all. So those first 5 kind of families that we went through are the most relevant ones. But I wanted to add one, and you'll pardon me for this because it's a bit of a personal reason. As I've mentioned, I'm a terrible sleeper. Um, and at one point was taking what I didn't know at the time, and I wouldn't have cared, what is in fact like the mirtazapine is. It's an atypical antidepressant, but it's called Trazodone. Trazodone, I just thought it was a sleep medication. And I can even, so let me briefly, very briefly, why I stopped taking it, and I am not giving any medical advice, is that it can have this off-target effect of increasing prolactin. And I'd had a blood test, this was about a year ago, and found that my prolactin levels were like 10 times higher than they should be in a man. Um, and so that was of course naturally very concerning. And since I've come off it, it's taken time. I've had probably 3 blood tests over the past year, through a company called Blokes, where they really do a very thorough dive into blood markers of health. And thankfully, when I first saw my prolactin levels, I actually worried that it might be a prolactinoma or a prolactin secreting tumor because they were so high. But I didn't have any other symptoms of like a pituitary tumor or a brain tumor. And then I realized that this drug had this effect on prolactin. And thankfully, as I was mentioning or getting around to, my levels have been steadily coming down. Now, having said all that, so I included Trazodone a bit out of a personal interest. So Trazodone is an atypical antidepressant that acts both as a serotonin reuptake inhibitor, so having a little bit of an SSRI, but also as a serotonin 2A receptor antagonist. So this makes it helpful for depressive symptoms and anxiety, with a consequence of having a sedative effect. So being very commonly used as a sleep aid. Now, it's the actual evidence that shows Trazodone having a metabolic effect is very modest. There is like a little evidence that suggests there could be some minor weight gain. But overall, of all the ones I've just mentioned, it is absolutely the most inert. Now, please, again, I'm not stating this to advocate its use. I just explained my own personal concerns with it. But the reason it didn't make that original list that I put together is because there's not a lot of evidence to suggest that it has any noticeable or substantial or meaningful metabolic effect, especially when used at the doses that it's used for insomnia. Now, I can't speak to the dosing that might be used for actual mental health use. For all I know, perhaps it does start to become more relevant, but even then, there's very limited evidence. That there's some evidence to suggest minor weight gain, but generally it has a relatively favorable metabolic profile, particularly compared with any of the others. All right, let's continue. Now that I've talked about the main antidepressant and anti-anxiety families of medications, I wanted to revisit something that I'd been touching on earlier, particularly with regards to the changes in appetite and cravings. Because some of these medications, like SSRIs, TCAs, and the antipsychotics, do interfere, as I've noted, with the regulation of hunger and satiety in the brain by regulating those hormones, the neurotransmitters that I mentioned earlier, serotonin, dopamine, and norepinephrine, all of which do have some influence into appetite. But it's not just a general, I'm hungry for everything that I can shove in my mouth. It does appear to make it a little more particular to mainly one of the 3 macronutrients. By way of brief review, the macro or big parts of the human diet are fats, proteins, carbohydrates. Humans really only show addictive tendencies to one of those, namely carbohydrates. Now, some people will say, yeah, but carbohydrates with fat are even more rewarding. I absolutely agree with that sentiment. However, there's no evidence that fat alone is the focus or the recipient of an addictive obsession, but there is plenty of evidence to suggest that carbohydrates are, alone or with fat. So let's just talk about that in a little more detail for just a couple minutes. So firstly, antidepressants and carbohydrate craving. Antidepressants, particularly TCAs, have been linked to carbohydrate craving and weight gain. So a particular craving for carbohydrate-rich foods. SSRIs have also been shown to do this, with some patients reporting increased carb craving And then lastly, the psychotropic drugs. Many psychotropic medications, including antidepressants and mood stabilizers, like ones I didn't talk about, including lithium, are known to increase appetite and, once again, carbohydrate cravings. So as the patient begins to, or the person using the medication begins to notice they're craving a certain type of food, the theme of all of these cravings is carbohydrates. Now, I felt compelled to mention that because one of the common ideologies, as we wrap up now, one of the common foundational causes or contributors, that's a safer word, that anxiety and depression have, that they share, is a phenomenon known as brain glucose hypometabolism. I've talked about this before. It's actually a foundational phenomenon for myriad neurological disorders, including things that you'd think none of which are related, like Alzheimer's disease, migraine headaches, epilepsy, depression, bipolar disorders, anxiety. These are all very, very different diseases, and yet they consistently share one thing in common, namely that the brain isn't able to obtain sufficient energy from glucose. Or if you measure the degree to which the brain in a person, say with depression or migraines or et cetera, is using glucose, it is less than the brain of someone who doesn't manifest with those neurological disorders. So that does suggest that in addition to any number of potential causes, and I do mean to state that emphatically, I'm not claiming this is the sole cause. I'm claiming that it's a common potential contributor across these two seemingly distinct problems, depression and anxiety. As often as they go hand in hand, they're not the same thing. So in addition to whatever other kind of noxious stimuli or diverse causes that may be contributing to each of these two distinct disorders, one common contributor is the fact that the brain is going hungry, and it's manifesting differently in different people. Now, that's particularly tragic in light of the fact that a general cause of this brain glucose hypometabolism is an insulin resistance of the brain. Because you see, the brain has some glucose transporters that are dependent on insulin. So it needs insulin to be working well to open those glucose transporter doors, if you will, thereby allowing the glucose to come in and nourish the brain. Now, the brain has two primary fuels. Glucose is one of them, and ketones are the other. Now, there's actually, the brain can also use lactate, but that I've mentioned that in the previous metabolic classroom, so I won't revisit it again, and it's generally more of a modest contributor. So glucose and ketones. Ketones are a tremendous fuel for the brain, a very viable fuel for the brain, and even perhaps the preferred fuel. Just to go on a brief tangent, as Dr. George Cahill has shown in previous studies, he found and published that even if glucose levels, or rather ketone levels, are lower, I'm just going to put out some numbers here. Let's say a fasting glucose is at 5 millimolar, and then a fasting ketone is at 2 millimolar. That's, of course, less than half of what the glucose is. Yet even in that metabolic state, the brain is getting most of its energy. Well over half of it, all of its energetic needs are coming from ketones. So if you have half of the amount of ketone compared to glucose in the blood or available to the brain, and yet it's accounting for almost double what the brain is. In fact, in some instances, it's higher. It can get up to 70% of the brain's fuel use. That clearly suggests a preference, and it's not for glucose. Now, why do I mention that? Because there are some papers published, and I have one linked here, showing that if you increase the ketones in a patient with mental health, like depression or bipolar disorders, you improve the outcomes. That ketogenic diets have been shown to improve mitochondrial function. They've been shown to improve neurotransmitter balance, and improving insulin sensitivity, helping the brain be more properly or adequately nourished. Okay, that's all I've got for you today in this lecture or this metabolic classroom. Just in conclusion, I approach this topic with a heavy, heavy dose of respect. It's very, very sensitive and even heartbreaking. These are real disorders with real struggles. But what makes things worse is that sometimes the treatment is inadvertently contributing to a key cause. So if a person is experiencing their anxiety and depression because of an underlying metabolic problem, how tragic is it that in some instances, the medication given to help alleviate the anxiety or the depression may be essentially just putting a Band-Aid on the problem while it is actually making the wound fester even more. So if you are exacerbating someone's poor metabolic health, you may inadvertently be exacerbating their mental health, even if the medication is giving a bit of a temporary, or I would say superficial, reprieve. Now, again, none of this is meant to be medical advice. My hope is that just by understanding some of the mechanisms behind these effects, particularly how neurotransmitters work, how the medications adjust the neurotransmitters, and through that adjustment or through direct effect are compromising metabolic health, my hope is that this is information that you can use to help just manage your own health and mental health and share some sentiments with those you care about. Thanks for tuning in. Until next time, more knowledge, better health.